I heard a glass of wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the NBC community having a good laugh.
Have you swam in Lake Tiki-Taka? Tiki-Taka?
Welcome to the Alamo Breast Cancer Foundation Advocate Chat. I am Dale Eastman, 23-year survivor of breast cancer and a 2-year thriver of metastatic breast cancer. I am a member of the Alamo Breast Cancer Foundation San Antonio Breast Cancer Symposium Advocate Committee. I am delighted to be hosting a chat with Dr. Richard Crownover, radiation oncologist at the University of Arkansas Medical Science College of Medicine. Thank you, Dr. Crownover, for accepting to do an ABCF Advocate Chat, especially when you just recently moved to Little Rock to accept a position at the Arkansas Medical Science College of Medicine. We're going to miss you in San Antonio, but you can't get rid of us. We'll be connecting with you.
Okay, good.
Today, I am going to be asking you questions regarding some of the talks and posters at the 2020 San Antonio Breast Cancer Symposium. But before we get started, can you comment on your new position at the University of Arkansas Medical Science College?
Well, so I've recently moved after 13 years there at the university in San Antonio, and we'll be treating breast cancer here, and we'll be doing quite a bit more mentorship in this new role. And that's probably the biggest change between there and here, other than the weather. So.
Oh, okay. You're farther from the ocean. But anyway, so let us begin with some of the San Antonio Breast Cancer Symposium talks regarding reducing toxicity and burden of radiation therapy and even omitting radiotherapy in select situations. Last year, 2019, there were some talks on cardiac toxicity. And this year, there seems to be some talks on cardiac toxicity again. What are your comments and thoughts about that?
Well, I think there's been a trend in radiation oncology to emphasize cardiac protection increasingly. And that's because as data has matured, watching women who've been treated many years ago and seeing the very long-term outcomes, we do see that there is a small but definite increase in cardiac events, meaning heart attacks or things requiring interventions like angioplasty, those types of things. And so that's been one thread that's led us to where we are right now. The other is that toxicity tends to be a pendulum between surgery and radiation and systemic therapies. And as the technologies improve with radiation, then that pendulum might swing more toward the use of extensive radiation. So the technologies have changed and allowed us to shape radiation around the heart much more effectively than we could have in the past. So those are two of the things. The other thing is we've seen data that shows us, again, with very long-term follow-up, that there's probably a small but real survival benefit to more comprehensive radiation to the nodal basins than had been used in the past. In other words, the threshold for using comprehensive nodal radiation has come down quite a bit. So when you take those three things together, we know the importance of protecting the heart. We know increasingly that there's importance to, in many situations, do nodal radiation, which by design can increase the dose to the heart with the older techniques. When you put all those things together, what we find is that the cardiac protection becomes very important, but it's something we can successfully do with things like selective cardiac shielding or with deep inspiration breath hold techniques or intensity modulated radiotherapy, which may include a breath hold technique as part of that. With those approaches, we can make this very safe for the heart. We bring the average dose of radiation to the heart for a left-sided breast cancer from about 3.5 gray out of typically 50 that we're delivering to our targets down to around 1.5 or less. The significance of that is that the increase in risk of cardiac events is about 7% per gray. So it's a very substantial difference at the same time that we're treating more extensively.
Okay. The next topic is radiation therapy for women over 65. So that includes me and many other elderly women who would like to hear what you have to say about that.
Are you drawing the line for elderly at 65? Is that what you just said?
Oh, that's no 65 and above. But
okay. So the way I
yeah.
describe that to patients is some things are a little bit different at a more advanced age, and that includes me. So there have been there's been a lot of interest in trying to identify subsets of patients that can have a lumpectomy but then don't need radiation. So the studies that were done that showed us that a mastectomy or a lumpectomy with radiation were equivalent a number of years ago really didn't have women who were at a more advanced age included in those trials. And so what's happened is after we had those results, we just had a one-size-fits-all answer, and that was that if somebody had a lumpectomy, they got radiation, not a lumpectomy without radiation. But there have been attempts to look at very small tumors, very low-grade tumors, some of the receptor constellations. And one of the things that has been looked at is the age of patients. And so we had a study a few years ago, it's been a decade now, that showed us that for women who were 70 and above, who were estrogen receptor positive, we probably could avoid radiation. Now, that didn't mean that it didn't decrease the risk of local recurrence, but what it meant was the amount it decreased it, the amount of benefit was so small that it probably wasn't worth doing. And so that's been one bar that was drawn, and people interpret that in different ways. Some people interpret it very strictly, and they say a small ER positive tumor in a woman 70 or older, they don't need radiation. Most radiation oncologists, I think, interpret it more in terms of the context of a person's overall health. So we would say that if somebody has a lot of comorbidities and their life expectancy may be more limited because of other things unrelated to the tumor, it probably makes sense not to use the radiation. But if somebody comes from a family where everybody lives, into their late 90s and they're in good health at the time we meet them, we're probably still going to lean a little bit toward adding the radiation. Now, there's been another study that's moved the bar downward for that kind of thinking from 70 to 65. That's the Prime 2 trial. And so in these trials, what we see is women with very strongly, and I would emphasize that part, Prime 2 showed us that they needed to be strongly ER and strongly PR positive, probably to leave the radiation out for that group.
The question I would like to ask now is for low-risk breast cancer, like DCIS, what are your thoughts about radiation therapy, or is active surveillance an option?
So active surveillance has always been an option for women, again, at more advanced age or with very serious kind of limitations on life expectancy because of other comorbidities, and particularly for women who had ER positive tumors, where we're going to have some endocrine therapy during that period of time. It isn't typically considered to be standard of care at this point of time, just to do nothing for most of those women.
Okay. A lot of women have a quality of life issue with lymphedema. And you did mention a little bit about the axilla and radiation therapy, but does radiation therapy, does it exacerbate lymphedema, or what are your thoughts on that you can share?
Well, I don't know that it would exacerbate it, but the quality of life in terms of the axilla, what we have learned from studies is that radiation for treating the axilla is often equivalent in terms of controlling disease at that site, and definitely has a lower morbidity. And what that means is if someone has a more extensive surgical dissection, their risk is higher of developing lymphedema in the future than if they had just a sentinel lymph node procedure, for instance, and then had full axillary lymph node radiation instead of that dissection. So I think that's becoming standard of care for many, many women to take that approach, using the radiation instead of the extensive surgery.
How does radiation therapy affect women who are contemplating plastic surgery? What is your advice for undergoing skin-sparing mastectomies, reconstruction, tissue expanders, or breast implants?
Well, as a rule of thumb, and this varies significantly by institution. So what you'll find, rather than a definite answer, what you'll find is different institutions have different policies, and we'll probably have to watch over the years and see which worked out the best. But as a rule of thumb, if somebody is expected to need radiation after their surgical procedures, most radiation oncologists will lean toward doing the reconstructions as a delayed procedure. And if somebody has a low enough risk that they're not expected to need radiation, there aren't expected indications for the radiation, then go ahead and do the immediate reconstruction. And then if at the time of surgery something is found or it's recognized in the pathology afterwards that indicates radiation, then go ahead and proceed, and you've got the implants in place or whatever kind of a reconstruction was done. But I think that's still the most common practice, at least in the United States, is to delay the reconstruction if you know that radiation is going to be needed because of a more advanced tumor or because of nodal disease.
Okay. So we're going to go to, okay, I'm sorry. So we're going to go to another topic, radiation therapy for metastatic breast cancer.
Mm-hmm.
And last year, there were a lot of women attending that did have brain mets, and they had a lot of questions, and they were in discussions on that. So is there anything that you can share with us on brain mets?
Well, for brain mets, if you went back not very many years ago, the standard of care would have been whole brain radiation and using surgery just for patients that had a larger lesion that was symptomatic and to kind of debulk, to take the mass effect away. There has been, again, with this pendulum swinging from one thing to another. For the majority of women with small numbers of brain mets, now we lean toward radiosurgery. So I'd say the algorithm looks like this. If somebody presents with brain mets and they have a large lesion that is causing a lot of mass effect, meaning it's pushing on some structure and causing neurologic problems or headaches or nausea that's intractable with steroids, then that patient's probably going to go to surgery as a first step to deal with that larger lesion. Although if there are other lesions, they typically will just address those afterwards with radiation. If somebody doesn't have an indication to go to surgery for one of the lesions, then rather than going directly to whole brain, now even for women who have 8 or 10, sometimes even more lesions, we're more likely to treat with something like stereotactic radiotherapy, because that treats just the individual lesions with very little dose given to the rest of the brain. The reason for taking that approach is that we get away from some of the late effects of radiation, like the decrease in short-term memory that can show up a number of months or a year after whole brain treatment. So we're trying not to employ that. Now, for the women that have, and if we do that, if we do the radiosurgical approach, what happens then is we typically are going to do another MRI. I'm making all kinds of gestures over here that you can't see on camera. So
I see it.
we're going to do another MRI about 2 to 3 months later to see if any new lesions have shown up, and then we may address those with radiosurgery as well. And we continue doing that until we see kind of a shower of mets. If we see a large number of mets, then we may go to whole brain at that point. But we're trying to push that whole brain treatment down the road further so that it happens later, where maybe we'll be in a situation where we're not going to see the effects on memory, so people have better quality of life.
Yeah, that's very important.
Now, a couple of comments, though, on whole brain. There's still some situations where that is the appropriate thing to do. And there are a couple of maneuvers that have been developed that, again, even with whole brain radiation, can decrease the effects on short-term memory and on sort of motivation, in a way, you might say. And one of those is a hippocampal sparing technique, which uses intensity modulated radiotherapy to carve out the hippocampi. They're two kind of seahorse-shaped structures, is what the pathologist named them after, that are located in the central part of the brain. And those, if you keep the radiation away, the high-dose radiation away from those, then it tends to spare the short-term memory. You see much less of an effect on it later. Another is a drug called memantine that can be given during the radiation, and then it continues for about 6 months afterwards. And either one of those approaches seem to diminish the impact on short-term memory. So even if a person has to have whole brain radiation, if that's what's indicated because of a very large number of lesions, for instance, we still see less of the changes in function that we've seen in the past.
Okay. There's a new drug that's been approved. And, I can't pronounce some of these. I'm going to spell it. It's TUCATINIB. And it's for HER2 positive breast cancer patients who have brain mets.
Mm-hmm. So one of the problems that we've had with systemic therapies, the drug therapies, is that they may be very effective elsewhere in the body. And so you can have a person who you don't see disease anymore, or it's responding very well elsewhere in the body, but still have progression in the brain because of the blood-brain barrier that keeps poisons out of the brain. And particularly with the HER2 positive tumors, with trastuzumab, it works amazingly elsewhere in the body, but we started seeing an increase in the number of HER2 positive brain mets because that's a place where that type of tumor likes to go. And so there's been a lot of interest in developing drugs that are effective specifically against the HER2 positive tumors that will get into the brain. And so I think that's what you're referring to there.
Okay. Then here's another word that I'm going to fracture it, but you're going to know what it is. It's OLIGO, metastatic breast cancer. How do you pronounce that?
It's oligometastatic disease.
Yes.
And so oligometastatic disease is a theoretical state of a tumor has metastasized, but not to very many places. And so rather than just saying, oh, someone has metastatic disease and now we're going to switch over into a palliative mode, there's this idea that if somebody has a very limited amount of disease, 3 or 4 or 5 sites that you can see, that if you have very effective drug therapies that can be given, then the place that's still going to harbor disease later to come back and be a problem is really arising just from those metastatic sites, those few metastatic sites. And so there's interest in ways to intensify therapy to those particular locations. And so that's where you'll see a lot of interest in using things like stereotactic body radiotherapy, very focused treatment, analogous to the radiosurgery we do in the brain, but to the metastatic sites. The idea is to try and treat for cure in the patients with just a very few metastatic sites, because the drug therapies hopefully can eradicate the microscopic sites. So in a way, it's kind of like what used to be done with, well, still is done, with patients without apparent or documented metastatic disease, but we're treating very intensively with surgery and radiation for the primary, but using chemotherapy to try and eradicate the possible microscopic disease. Well, this is taking it a step further and pushing that curative approach to a group of metastatic patients.
Okay.
There's another closely related term that's called oligoprogression, and that's a very new term, and I don't know if you want to talk about that as well.
What do you want to comment on that too?
Well,
that's fine.
My comment there is oligoprogression is a little bit different. So that's a situation where someone has measurable metastatic disease and they're being treated with some systemic regimen, some drug therapies, and it appears to be working because the disease is either regressing or stable at most of the sites that you can see and measure. But oligoprogression would refer to the situation where maybe someone has 8 lesions that you can see, and 1 or 2 of them are growing while the rest of them are stable or regressing. And so the typical response of a medical oncologist when they see that is, oh, now we need to change regimens because this isn't working. But the idea of oligoprogression is that it is working for most of those sites. And so quickly running through the number of regimens that you have that can be effective and getting to the end of that, if you have oligoprogression, you can treat locally, either with surgery or again with stereotactic body radiotherapy, something that's an intensive local therapy just for the 1 or 2 lesions that are progressing, and stay on the regimen that's controlling the other sites to get more benefit from that before later needing to change to something else. So you don't go through those various regimens as quickly.
Thank you. What about radiation therapy to other metastatic sites, like lung and the liver?
So those are, those are fairly common sites for, again, the stereotactic approach that we use in the brain. And so the techniques are fairly well developed now and becoming fairly widely available for treating both the lung and the liver. And one of the reasons those are kind of exciting is both of those organs are very sensitive to radiation. So if you use conventional techniques to treat a lesion that's in the lung or in the liver, you're going to do a lot of damage to that organ in the process with conventional techniques. But if you use the stereotactic approach, then you're treating from a lot of different directions. You've heard me say this before, no beam carries much radiation. So the only place there's a high dose of radiation is right where those beams are intersecting. And so you can go in and very selectively treat spots in these locations without causing the lung or the liver to stop functioning. The role of that really is either for oligometastatic disease, a limited number of lesions where you're thinking, okay, if we treat these, that may actually be the only disease that's present. So treat them very intensively with what is considered an ablative dose of radiation. The other situation where we would use these would be if somebody had a lesion that was likely to cause problems. Either it was causing pain, or if you use the lung as an example, if it was located near a major airway, where if it continues to grow, it might pinch that off and cause a part of the lung not to be aerated and not to be working. So we use it to reverse or prevent symptoms, or we use it in an oligometastatic setting to still try and push the envelope on cure.
Okay. Now, this was not a topic at the San Antonio Breast Cancer Symposium, but I wonder if you could just spend a minute or two on it, because I think it's very important, because the people that'll be viewing these chats may be newly diagnosed or living with breast cancer. How can radiation control cancer pain? Or can it?
Yeah, it can very effectively. For instance, bone lesions. If someone has a bone lesion that is causing pain and it's not responding well to the drug therapies that are being given, and by that I mean active treatments, not pain medicines, but it's not responding well to those, then the radiation can very effectively decrease pain and reduce the amount of pain medication that's needed. And in the majority of cases, it can take the pain away at the site we're treating. And so palliative radiation has a well-established role. It's used if there's pain. It's also used in the skeleton if there is a weight-bearing lesion that is structurally threatening. So one of the things we've gotten better at is predicting what's going to be a problem and trying to prevent it from happening. So if we see a lytic or bone destructive lesion in the hip, for instance, or in the low spine, those are areas that carry a lot of the body's weight, and it's possible for them to fracture easily. And so we would treat those with radiation to let the body start rebuilding the bone. And as long as there's enough of the skeletal structure that's still present, the body's really clever at rebuilding the bone. It takes usually about 3 months, though, for the strength to really come back. So what we're typically counseling our patients about is we're going to treat, hopefully here in a couple of weeks, it's not going to be hurting as much or hurting at all, but don't go out and do jumping jacks for 3 months because you still could fracture something. So that's an example of where radiation would be helpful with pain. Another example I already gave is in the lung. Sometimes we'll give palliative treatments if we see a central lesion that's near the area where the major bronchi, where the trachea is splitting and then fanning out into the lung. Those major airways, if we see something growing there that's starting to compress them or threatening to compress them, we may go ahead and treat that even though there are no symptoms, because we don't want those symptoms to develop. In that example, the major airways, if they close, with radiation, we have about a 20% chance of reopening it. But if we treat before it closes, we have about an 80% chance of keeping it open. So that's why surveillance and paying attention to where things are developing becomes very important.
For the present situation of COVID, what are you radiation oncologists telling breast cancer patients that will need to receive radiation therapy or are already in therapy about their appointments?
Okay. So radiation oncology, that's been handled differently again in every department. It's certainly handled differently here in Arkansas than it was in San Antonio, and as I talk with other people around. So some larger departments have split their faculties so that everybody's not present on the same day. So, they'll come into the clinic a couple of days a week, and then the other people will come into the clinic a couple of days a week, so that if someone got sick, everybody's not going to be out at once. In terms of how COVID affects the patients, if we typically are going to be testing right before somebody is simulated or right before somebody starts treatment. And if somebody has an early stage tumor where their treatments can be put off if they had a positive test, where they can be put off for a period of time without negatively impacting their treatment, which in some situations is actually several months safely, then those patients are probably going to come back and be treated after they're feeling well. If somebody is already in the midst of treatment and they become positive or they're exposed to someone else, then they're probably going to be quarantined more carefully from the rest of the population of patients and staff. So, for instance, many departments would have those patients come in and be treated at the end of the day, so that after they're treated, they can do a high clean of the room before the next group of patients are going to come in the next morning. But in terms of interrupting treatments, people wouldn't be stopped from treatment in the middle, but they are counseled at the beginning of treatment to be very careful. They're tested and then asked to be very careful about social contacts and community contacts until they're done with treatment to try and avoid interruptions. Because sometimes there are interruptions just because somebody's sick and they don't feel well enough to come in.
Okay. I'm glad that we had a discussion on that because it's so timely. Do you have any additional comments you would like to make? Because this is near the end.
I think some of the really interesting things from the meeting last year had to do with hypofractionation. And so there's been this trend toward treating many of the patients with a 2 to 3 week course of treatment rather than a 5 or 6 week course of treatment. And I think that's turned out to be a really promising avenue that is making the burden of radiation treatments much less for a large number of patients. I think what we've also seen is the accelerated partial breast irradiation probably was a very bad idea in terms of not necessarily local control, but in terms of long-term cosmetic outcomes. And so I think that's being established now. But I think people need to have clearly in mind that there are a number of things that are being discussed. One is hypofractionation, which just means a smaller number of fractions over a shorter period of time usually. The partial breast irradiation is a different thing, treating just a portion of the breast where the tumor is located and then generously around it, as opposed to the entire breast. I think that's turning out to be very promising. But the accelerated, very aggressive partial breast irradiation, the twice a day for a week kind of schedules, probably are going to disappear from our armamentarium, with the exception of patients who it's very inconvenient for them to be treated, or their life expectancy is perhaps a little bit more limited by other factors. Those patients might still decide to be treated with an accelerated partial breast approach because the long-term cosmetic outcomes aren't such an issue. Or let's say somebody that lives very far from a radiation center might just say, that isn't my priority, I can only be here for a week. And so those kinds of schedules are probably not going to be used so routinely, but they'd still be available in very selected situations where the patient agreed with that approach. And so I think that change is one of the major things that came out of the meeting last year from the results that were presented.
Okay. Well, thank you. I can't thank you enough for accepting to do this. Just working with you again, it's a pleasure. And this information that you gave us today will be helpful to newly diagnosed breast cancer patients and those living with the disease, metastatic patients, and patient advocates. So thank you again, and I wish you well, and stay safe.
You're very welcome. Thank you.
I heard a glass of wine can prevent cancer, or does it cause cancer?
I don't think this video is about scolding those people that love and care and those people that have misstepped with their words.
Have you tried yoga? Yeah, I have.
I think this is really about the MBC community having a good laugh.
Have you swam in Lake Tiki Taka? Tiki Taka?